I'm honored and excited to present to you our keynote speaker today, Dr. John Aucott, who is an associate professor of medicine and director of the Johns Hopkins Lyme Disease Research Center. And today he'll be talking about something that I think that is of broad interest and very exciting. So the title of his talk today is Long Haulers, Lessons from Lyme Disease, MECFS, and COVID-19.
Thanks, Monica. I want to thank Pat Smith and Brian Fallon and Monica for the invitation to speak today. I have some disclosures, but none of them are financial arrangements or affiliations with commercial entities. I'm going to be talking today about the broad topic of infection-associated diseases or infection-triggered diseases, which really have a long history, going way back to rheumatic heart disease and its relationship to group A strep, Campylobacter and Guillain-Barré syndrome, trypanosomiasis and carditis. And then many of you may not know reactive arthritis and rheumatoid actually is likely triggered by infectious diseases. And then spreading out from that, the topic today is really going to be these groups of infection-associated or triggered illnesses that share a common patient picture or phenotype that also have a long history, going back to the Russian influenza outbreak of 1889, ME, chronic fatigue syndrome linked to Epstein-Barr virus infection, fibromyalgia, which may be linked to preceding viral illnesses. The main topic of today, Lyme disease and chronic Lyme disease and how that is linked to previous triggering by Lyme disease. And then the newest connection here is the COVID-19 and long haul COVID, which really sparked my interest again in what is shared by these illnesses and what we can learn from these different illnesses. So you all know the COVID long hauler is a big deal. The incidence varies, but it can be between 36% and even more depending on the studies. It can occur very importantly in mild as well as severe disease. So it's not just people with severe COVID that get long hauler. Women may be at higher risk. And very importantly, it's not just the background of the population. In other words, this isn't just the hum of fatigue in the general population, and it occurs more than in the flu. The figure on the right shows long hauler features in COVID compared to after influenza, and you see it's much higher after COVID than influenza. And in the right panel, you can see that these symptoms don't always just start at the beginning. Sometimes the symptoms in long hauler COVID don't even initiate till a month or two after the initial infection. And these are serious and cause significant loss of function. In other words, this is a big deal. This is similar to what we've described in Lyme disease. This is a summary slide of our SLICE cohort that looks at long haul Lyme disease, so to speak, after early Lyme disease with erythema migrans and treatment and 6-month follow-up. And what we've shown is that only 57% of people at 6 months return to their normal pre-Lyme health. 30% have symptoms but are functioning well, but 14% meet the case definition of post-treatment Lyme disease. In other words, they have long haul Lyme. They're still not back to their normal health 6 months later. And again, this isn't just the hum of the population. We have matched controls in the SLICE study, and only 4% of non-Lyme infected controls develop the same phenotype or symptoms as the long haul Lyme patients. So 10% higher than control. So this is, again, in these illnesses, infection-triggered illnesses, a real long haul clinical illness. And it's not trivial. This is a projection of how many cases of long haul Lyme there would be over time. And it's up in the hundreds of thousands, if not more than 1 million. You know, that's with 400,000 cases of newly diagnosed Lyme disease a year. Think how many cases of long haul COVID there are going to be with 44 million cases of COVID now having been diagnosed in the United States. Long haul COVID is going to bring more attention to these similar groups of patients with chronic illness. When I first saw the symptoms in long haul COVID, it was strikingly similar to the symptom patterns we see in Lyme disease. And this just shows how the symptoms in long haul Lyme are much different than controls. But when you put it next to the long haul COVID symptoms, you see they're almost identical. Fatigue, aches, difficulty concentrating, difficulty sleeping, looks just like our long haul Lyme patients. The only thing that's a little different is the long haul COVID patients have more breathing problems. So I want to give you a case report of a patient with long haul COVID. This is a 49-year-old healthy woman, had actually a mild case of COVID, fatigue and malaise. She didn't even think she had COVID when she talked to me, but she developed 3 days later the complete loss of taste and smell, but never developed the typical respiratory symptoms of COVID. But she was PCR positive for COVID. And over time, she got her COVID vaccines, but her symptoms didn't go away. You know, a couple months later, she still had only 50% of her taste and smell. She had recurring flu-like symptoms. I've known her now for 8 months and she's almost back to normal. But as of just a month ago, she still had these unique smell problems of, you know, bananas taste like burnt sweets. She could taste chocolate, so she was good with that. But this just illustrates how symptoms in these illnesses are sometimes the key feature. Now, in loss of taste and smell, we can link that to the olfactory nerves and the pathways that control our ability to smell odors. And so it's easier to believe this kind of symptom that I can't smell. But as you all know, many of the symptoms in long haul COVID and long haul Lyme aren't easy to believe. They're things like fatigue or pain or myalgia or cognitive symptoms. And these kind of symptoms, this is one of the first lessons, is these symptoms and these long haul illnesses are hard to tie to a pathway that is an etiologic pathway. And so we pointed out in this Lancet editorial that patients often are not believed. And Allison Redmond and I wrote that these symptoms like fatigue and cognitive things we've learned, you know, are often contested, that patients aren't believed. And we wrote that we shouldn't dismiss patients just because their symptoms aren't linked to a biologic pathway that's easily understood. And that just because the objective findings of a disease resolve, like the rash of Lyme disease resolve, doesn't mean that the whole story's over. The patient's symptoms are important and they're real. Now, in COVID, we're going to see that, you know, diagnosis is helpful for understanding who has COVID. You all know that in Lyme disease, unfortunately, serologic diagnosis is not good. In the acute phase, two-tier testing is only 30 to 40% sensitive. It may become sensitive in late Lyme arthritis, but that's not where most of our long-haul Lyme patients live. They live in this kind of convalescent phase after erythema migrans, where again, two-tier testing is not sensitive at all. A huge range reported here, but usually under 50%. And so diagnostic testing for long-haul Lyme disease is very difficult. That's different than COVID, where we see that PCR testing is available. And so when somebody has acute COVID, we can confirm that with a PCR test that directly measures the virus, the COVID-19 virus. We don't have PCR tests for Lyme disease. And so diagnostic testing to confirm Lyme disease is still at a primitive stage. And COVID teaches us how important it is to have a direct diagnostic like a PCR test. The other thing that COVID teaches us is that pathology is important, that being able to see damage, acute COVID, of course, that's primarily lung damage, but also other organ damage, that to see that on pathology is crucial and is important to establishing the link between the disease and the long haul symptoms. And in COVID, we can do that because acute infection, again, shows up on chest x-rays and CT scans. And it allows us to kind of lay out 4 scenarios for COVID disease. There's, of course, the acute disease in the top panel, but then there's diseases that are autoimmune, that are immune-related manifestations that can come on after the acute damage in this late phase. There's also damage that never repairs itself. So in the third panel, there's patients that have organ damage like lung damage or heart damage that never repairs itself. And so they have chronic symptoms from objective organ damage. But the area that relates to Lyme disease more is this long COVID, where the acute symptoms resolve, but then persistent symptoms persist, the long hauler phenomenon, where fatigue and cognitive complaints persist for weeks, months, and even years, and they're not explained by the initial infection, albeit they're triggered and associated with the initial infection. So COVID kind of has given us this outline of the different mechanisms. And when you look at COVID patients, this is a big study from Nature in April, you can see in green that patients that were never hospitalized can develop symptoms, long haul symptoms, just like patients that were critically ill in purple. But what's interesting to see is that things like stroke, where you would get hospitalized, don't appear much in outpatients that have mild illness. In other words, you can have long haul COVID without having damage like a stroke to your brain. But patients with mild early disease in COVID do get a lot of memory problems. So there's this whole, again, dichotomy between structural damage that's easily seen on CAT scans and imaging and blood tests, and important patient-reported symptoms that's not so easily observed and happens even in patients with mild illness. So people have outlined the possible mechanisms of long-haul COVID, and I'm going to go through these because you're going to see they're remarkably similar to the mechanisms we've hypothesized for long-haul Lyme disease. And these mechanisms include subtle brain infection, autoimmunity, blood flow changes with brain ischemia, altered blood-brain barrier with passage of inflammatory mediators into the brain, and cytokine-induced fatigue. You'll see that these are actually quite similar to what we've hypothesized in long-haul Lyme, where we've talked about persistent infection or antigens in structures, including the brain. We've talked about immune inflammation and dysregulation, either driven by microbial pathogens or autonomous in autoimmunity. And we've talked about neural network alteration, all these things that are, again, being pointed out as mechanisms for long-haul COVID. So what can we learn from long-haul COVID? Well, in COVID, patients, we often have the advantage of having autopsy material, unfortunately. Patients with COVID-19 often die. And because of that, we have autopsy material. And we've seen that it's actually hard to find the COVID virus in the cerebral spinal fluid of patients. There can be some perivascular infiltrate, but actually the identification of the virus has been tough. But there is microglial activation and inflammation in the brain. These are themes that I'm going to hit on over and over again. So the first evidence is you can find COVID-19 virus in brain sections, but the key point is they're few and far between. And so you can see rare viruses have been described in the brains of people that passed from COVID-19, but they're hard to find. And these reports actually have not been confirmed in all the studies to date. So it's an ongoing investigation, but that's a theme that COVID tells us. Even when you have pathologic material, it's hard to see the virus. Now, of course, Dr. Embers knows this very well. This is an image from her outstanding work where similarly, it's hard to see Borrelia burgdorferi, even when you have pathologic material from animal models or humans. They're few and far between, but with meticulous examination, you can find rare organisms. What I think is really interesting is that these organisms are also associated with microglial activation. Again, this is a theme I'm going to hit on over and over again, is that COVID and Lyme disease share this feature that maybe the organisms are triggering inflammation, especially inflammation in the central nervous system, like microglial inflammation, that we're going to talk about how that may lead to the symptoms of long-haul Lyme disease and long-haul COVID. We'll have a speaker later today, Dr. Brissett, that will talk about that maybe the infection doesn't even have to be in the brain. Maybe infection adjacent to the brain and the dura can trigger inflammation in the brain. And so that, the organism and inflammation don't have to actually even be in the exact spot or the organ that's being infected. Maybe the brains of humans are being affected by infection at sites that are either distant or adjacent to the brain. And finally, what are the actual components of Borrelia burgdorferi that are triggering the inflammation? This is an outstanding study by Christine Jacobs-Wagner's group that looked at peptidoglycan that's shed during the growth of bacteria and hypothesizing and showing data for the presence of these neuropeptides that can actually trigger inflammation. So finding out what are the components of the microorganisms that may cause the inflammatory insult that's going on. So second lesson from COVID-19 is this autoimmune hypothesis. This is one we're interested in at Hopkins and in my colleagues in the rheumatology division. And they were quite struck by how many autoimmune diseases can be triggered by COVID. Kawasaki's, arthritis, Guillain-Barré, again, thrombocytopenia, thyroiditis. You may recognize some of these like thyroiditis as being prominent in long haul Lyme as well. So it's this whole idea that it's probably complex. It's more than just the organism and the inflammation. Maybe there's autoimmune causes of the symptoms we're seeing that are associated with long haul COVID, definitely, and long haul Lyme, probably. And then making a transition, I'm going to pull in MECFS. So this is an important infection-associated and triggered illness that I think we're learning a lot about and haven't paid enough attention to in the chronic Lyme field, because this is being brought out again with long COVID. These illnesses share more than they're different. So the core symptoms of MECFS are impairment in activities, post-exertional malaise, unrefreshing sleep, cognitive impairment, and orthostatic intolerance. Sounds familiar, right? A lot of these are shared by long haul Lyme disease. So what can we learn from this illness as well? Well, an important thing that was, again, peaked by COVID is that many of these post-COVID patients have postural orthostatic tachycardia syndrome, which has long been an observation in MECFS, is that these people with chronic fatigue have POTS, but the post-COVID patients do too. This is a 30-year-old with chronic fatigue that shows a typical tracing of the increased pulse rate that occurs when the patient goes from laying to standing. Here, a 77 beat increase in pulse rate that then comes down when the patient lies down again. This is a classic POTS tracing of tachycardia with standing that's long been seen in chronic fatigue syndrome, but now is being seen in post-COVID as well. And these patients with POTS have reduced cerebral blood flow. This is a plot of cerebral blood flow. And you see that cerebral blood flow decreases in POTS, which makes sense why the patients with POTS have cognitive symptoms of fatigue, right? They're not getting enough blood to their brain. But what's interesting is that all the chronic fatigue patients, even those without POTS, have this, many of them have this similar reduced cerebral blood flow, and it's markedly different than controls without orthostatic intolerance or chronic fatigue. So we're probably missing patients that have decreased cerebral blood flow, even if they have normal tests for POTS. So this is a core feature of chronic fatigue, is this orthostatic intolerance and its association with fatigue and cognitive symptoms, now being played out again in COVID long haulers and probably unrecognized in the Lyme, chronic Lyme long haulers. And this has been pointed out at Hopkins, where our POTS clinic is starting to see a huge influx of patients with long haul COVID are flooding our POTS clinics at Hopkins. So now I want to shift the focus a little bit about mechanism here. What is it that may tie this together? So the vagus nerve we've become very interested in is possibly a mediator of POTS and many of the symptoms that we're seeing in these illnesses. The vagus nerve is a cranial nerve, right? Reminds you, right? Lyme disease likes to infect the cranial nerves. Well, this is the 10th cranial nerve, the vagus nerve. Its cell bodies are up in the dorsal medulla. And 10% of the vagus nerve fibers go away. They're efferent. They travel away from the brain. And in POTS, the obvious fibers that are important are the ones that travel away, go down through the vagus to the heart. And those could be a mechanism that ties together vagal nerve dysfunction to POTS, right? Because if regulation of pulse and cardiac function is altered by abnormal vagus function, that could be the mechanism for POTS. Interestingly, we're going to come back that there's also efferent fibers that travel in the other direction from the dorsal medulla that go up into the brain. And I wasn't even aware of these fibers till I started researching this. These fibers that go back into the brain actually go to the limbic system, the amygdala, and areas of the brain that are central for regulating emotions, behavior, and memory. Sound familiar? Another potential link to a mechanism. Why do long haul patients get altered emotions, behaviors, and memory? Well, one potential theoretical mechanism are these fibers of the vagus that go up into the brain. Now, the afferent or sensory arm of the vagus are the fibers traveling from the body back into the vagus nerve nuclei. Now, these circles all represent the diffuse areas around the body where fibers sense things. These are ganglia that sense bacterial infection, inflammation, and send that information back to the brain. So these fibers are sensory. It's actually 90% of the vagal fibers are collecting information from our organs and bodies about inflammation, glial activation, maybe. And there's the glial cells again, and taking them back up to the brain, to this area called the nucleus tractus solitarius, an incredibly important area where then signals again are sent up to the brain that may do transmit sickness behaviors like fatigue, nausea, memory problems that are part of an acute sickness behavior evolutionarily, but in long haul patients become a chronic sickness signal that's inappropriate, that sends intractable signals of sickness to the brain and makes us feel, as my patients have often told me, that they like have the flu that will never go away. So the vagus nerve to me represents an attractive hypothesis for the mechanism of symptoms in these long haul patients. So let's finish up maybe with some treatment hypotheses based on this vagal nerve hypothesis and this inflammatory process. So these are not all the treatment hypotheses, but ones I've been interested in recently. First is the role of anti-inflammatory antibiotics. It's really interesting that the tetracyclines are actually commonly used to inhibit microglial activation. Now, if we think that the microglial activation is part of the brain inflammation, the vagal nerve inflammation and dysregulation, maybe some antibiotics are acting both as an antibiotic and as an anti-inflammatory for glial cells. Maybe there's antibiotic combinations, and Monica Embers will be talking about this later, that can affect the organism and the triggers that it's causing to cause inflammation. We'll talk about vagal nerve stimulation, mindfulness, POTS, and end with some provocative information about cervical spine compression and gut microbiome. This is a PET image showing glial activation that we've reported. Doxycycline and tetracycline dramatically inhibit this glial activation that's seen on PET imaging. And so maybe these agents are useful as both antibiotics and anti-inflammatories. I've been very interested in vagal nerve stimulation, which is actually approved in the US for epilepsy and for depression, and maybe could be investigated in the future for its impact in long-haul Lyme and long-haul COVID. Now, maybe vagal nerve stimulation is a way to re-regulate these abnormal vagal stimuli and effects that I've talked about. Treatment of orthostatic intolerance and POTS, I think, is huge. My colleague here at Hopkins, Dr. Peter Rowe, who's an international chronic fatigue expert, is one of the mainstays he uses in his chronic fatigue syndrome, and it involves non-pharmacologic treatment, medications, and contributory conditions. And it's really a core part of his therapy of chronic fatigue. I want to point out a little bit about contributory conditions, and one that I wasn't aware of that Dr. Rowe has taught me about. And this is cervical spine stenosis and Ehlers-Danlos syndrome. In this study that he co-authored, and where they looked at orthostatic symptoms in patients with Ehlers-Danlos syndrome, and showing that in this case series, the Ehlers-Danlos patients had lots of orthostatic POTS-like symptoms. These symptoms could actually be ameliorated in select patients by repairing surgically, they're repairing their atlantoaxial instability of their cervical spine. implying that people with instability of their spine or stenosis of their cervical spine may be compressing these pathways of the vagal nerve that we were talking about, contributing to orthostatic intolerance and syncope. So I just point this out, not that every patient has this, but part of our workup should be looking for Ehlers-Danlos syndrome or cervical instability or stenosis potentially in patients that have symptoms suggestive of that. And then I'll end with some data from Kim Lewis's work with us on microbiome. We think that this is also a potential, we know it's a signature in post-Lyme disease syndrome in our studies with Kim Lewis, and maybe this is another route to intervene in what's going on in our patients. So I'll just end with hope that research is knowledge and knowledge is hope. These are all the collaborators we're currently working with, a large group of people around the country. And we are actually quite hopeful that this knowledge that we're producing will provide hope. And I think the long haul COVID epidemic and the knowledge from chronic fatigue is starting to come together with our research to really find and suggest and elucidate some specific interventions that we can study to see if they can help our patients. And I just thank all the people at my institution that have been part of this, and we're just thankful for the being asked to present today our work. And with that, I'll finish up and take any questions that are available.